First, I want to welcome all of you here in attendance, as well as those who are tuning in via the stream. We are really making a lot of efforts to make sure that this training is available and accessible to all, including those who are not able to make it here physically. Also, it is a recorded session as well, so if you have some friends who also were unable to make it physically here today, they'll be able to access it after, as it will be uploaded to our website. So a few housekeeping items, just want to cover briefly. There are 2 sets of bathrooms right out of this exit behind you. Out of those doors, there's bathrooms over to your left, all the way to the end of the building, and then also to your right. As far as exits, just being aware, again, there's an exit behind you. There's also one here to my right and your left. And just as a reminder, please no food or drinks in the auditorium. We'll also ask that you turn all cell phones to vibrate or silent mode. With that said, I'd just kind of like to introduce myself. My name is Dayton Romero. I am a co-chair of CRAP. I've been on the committee for about 4 years now, and it's been an absolute pleasure to see the topics covered and the evolution of this committee and the work that they're doing and moving really toward the mission. The CRAP mission, just as a reminder, if you didn't see on the flyer, is to promote statewide understanding of elder and at-risk adult abuse and the rights and protections available to elder and at-risk adults. So with that being said, I'd like to introduce our CRAP steering committee members. Our newest is here with us today in the front row. Her name is Kyra. So just quick round of applause for Kyra. Thank you so much. She is an ombudsman and really brings a great talent and skill set to the steering committee. And again, in all of our efforts in broadening the reach and awareness to this important issue. Another steering committee member is Jenny Creasy, who just walked in as well. So we'll give her a round of applause as well. Again, very great members to be great members on this committee. So some other reminders here are training evaluation forms. Please complete them and let us know what you think of our training and topics you would like to see us see in the future. You will receive your certificate of attendance for continued education credits at the table by the door on your way out, and you may ask questions during the presentation. We will have some mics going around during the presentation. Next, just a quick summary of the presentation. The training will emphasize the importance of providing person-centered and trauma-informed care as a vital component to ensuring care recipients are involved in and respected for their individual differences and past traumatic experiences. Placing people at the center of their care has multiple benefits, including improving the quality of services provided, helping people obtain the care they need when they need it, empowering people to be more active in their care, and reducing some of the pressures experienced by those working in law enforcement, protective agencies, and the helping professions. This training is tailored with the goal of better serving Colorado's most vulnerable community and their families while continue to embrace a culture of partnership, collaboration, and individual empowerment. I will move forward with introducing our speaker today, Dr. Gibson. She received her PhD in clinical psychology with an emphasis in geropsychology from the University of Colorado, Colorado Springs. She is an instructor and clinical supervisor for the psychology department at UCCS and a faculty affiliate with the UCCS Gerontology Center. Dr. Gibson serves on the editorial board for the Journal of Elder Abuse and Neglect and is a member of the research committee for the National Adult Protective Services Association and a member of the Pikes Peak Elder Abuse Coalition. In addition to being an advocate for elder justice, Dr. Gibson has a private psychotherapy and consultation practice, which includes provision of capacity evaluations, expert testimony, consultation, and training. With that said, it is my pleasure of introducing Dr. Gibson. Thanks.
Thank you. Thanks, Dayton. Thank you. Hi, good morning, everyone. Yes, give it to me. Back. Good morning. It's so great to be here and to provide this training to you all on behalf of CRAP. I chaired CRAP for a number of years, and I'm very pleased to see the continued growth and expansion of great training to professionals, not only here in our immediate region, but now anywhere being able to stream live online. Isn't that amazing? So there are colleagues across this state and across the country who can also access these resources, which is an important mission of CRAP as well. So I want to start off by we have to talk about person-centered care before we talk about trauma-informed care. And I want to ask and pose a question to all of you. Think for just a moment, if we were to meet in an elevator and I said, what does trauma-informed care mean? I keep hearing this term. Tell me what this is. Anybody have an idea? There's no right or wrong. And I've got microphones coming, so just pause a minute. I want to make sure that people who are hearing this can also hear your response.
Trauma-informed care means to acknowledge and be mindful that trauma is a part of a person's intersectional identity.
Wonderful. So that's the trauma-informed piece, which is great. Let me back up for just a second and ask, what is person-centered care? Yeah.
I think person-centered care basically means that you're looking at the whole person and allowing them to be involved in their care, be the center of their care, have their opinions and their experience work within that realm of caring for them.
That is
not
true.
Leaving them out.
Right. So the person is at the center of their care. Correct. Anybody else want to add something else to that definition? Your understanding of person-centered care. Well, I think you've really touched on it quite nicely and comprehensively. So let me ask you this question. How do you know when you're doing person-centered care? How do you know when it's working? I know I'm asking a lot of you early in the morning.
For me, it's really simple. Sometimes when you're reflecting back to a client and they look right at you and they say, exactly.
So they validate, yes, you got it. You're getting it. Right. Anybody else? How do you know when it's working? When you're being effective in person-centered approach. Yeah.
I'm not sure if this mic works. I'll try to project.
No, Leah has to run.
Thank you, Leah. I would say really working alongside with the person and utilizing their strengths, and it kind of being a collective effort where they're contributing, they recognize their strengths, and they're using those to kind of move forward toward a common goal, toward a goal that is agreed upon between the two.
Great. So agreed upon between the two parties. So people are working together. You see engagement. Engagement is kind of a key factor in person-centered care. Would you not agree? People are engaged. Now, let me ask you the converse question, which is, how do you know when it's not working? When you are not effective at person-centered care? Yes, right here.
Continual resistance from the person because they don't feel like their needs are being met or that they're being heard, and there's no results. It's just a constant back and forth battle.
Constant back and forth battle. There's no results. You're feeling resistance from that person. What else? What other behaviors do you see when it's not working? Yes, sir.
No response.
No response.
Right. They don't or hardly respond to your comments or to your suggestions.
So it's shutting down.
Right.
Shutting down. Anybody ever been fired by a client? It's okay. We're not shaming here. Anybody ever had the door slammed on you? Won't take your call? Hangs up on you? Uh-huh. That's how we know when person-centered isn't working. So here's the key thing, the key thread that runs across all of that is the relationship. It is all about relationship. And so this training is really about how healing occurs in relationship for people. When people are not engaged, and some of the terms that really get under my skin as a psychologist is when I hear non-compliant, non-adherent, manipulative. Those are some words, some adjectives that embedded in those are negative judgments about our clients, right? We hear it all the time. But it's really about engagement. And when I see that people are not engaged, my question is, where have I gone wrong as a provider? Where am I not getting it? Somehow along the line or along the continuum of my care with this person, I've missed something. And now we've got to have a conversation about what's changed. Where am I not seeing you? How am I not meeting you here? And that's really at the core, I think, around one, person-centered care, and two, trauma-informed care, which is person-centered care. How many of you in the room have actually attended a training already on trauma-informed care? Okay, so bless your hearts for being here to hear it again. And I will say that even though you've had training, I hope that, one, being reminded of some of those basics again and again bring you closer and closer to the topic. And two, that we are always just reminding ourselves that we never know it all, right? We never know it all. I have given this training at least a dozen times, if not more. And every time I give the training, I think about it differently. Every time I do it, the kaleidoscope just shifts a little bit, that I see the picture in a whole new light. And a lot of that happens because of the interaction that you and I are going to have throughout this conversation. And I hope it is a conversation, because I think that with all of us here, you bring a diverse experience and understanding about trauma. So I'm going to launch right in now. Here's what we know from SAMHSA. SAMHSA is the Substance Abuse Mental Health Services Administration. And SAMHSA is kind of at that government federal level. They've done a lot of studies and work around trauma-informed care. And some of the main key points that have come out of their work are three things. One, behavioral health is essential to overall health. Prevention works, and treatment is effective. And we'll talk about the difference between trauma-informed care and trauma-specific care. We're talking about trauma-informed care today. Here are the four elements that you really need to know. Trauma-informed care requires us to, one, understand the prevalence of trauma in our society. Recognize how trauma impacts individuals at the individual level, and then putting that knowledge into our practice so as we actively resist re-traumatizing individuals. How does that look? So one of the things that I'll do with you today is I'm going to bring in some of my own case examples, because I think it's important to kind of put meat onto the skeleton. Let me give you an example. I was working, prior to going into private practice, I was director of behavioral health for Rocky Mountain PACE, the program of all-inclusive care for the elderly. And in that work, I worked individually providing psychotherapy services to older adults. And I was working with this woman who had a very significant childhood abuse history. Which is not uncommon, especially when I find working with older indigent individuals. And she had done a lot of work in her life. Over her life, she'd been hospitalized multiple times on inpatient psychiatry. She had a diagnosis of bipolar disorder. At some point, way back in her history, somebody thought she had schizophrenia. She had been in and out of therapist offices for a very long time. As an adolescent and young adult, she started cutting herself as a way to deal and cope with the trauma of her childhood. And when I finally got to see her and work with her, she was in her late 60s. And one day she came to our session and she was inconsolably crying, sobbing. And I just sat with her until she could finally pull herself together, and I asked her what was going on. Well, it turns out that my client had, over time, had become more and more incontinent as her physical health declined. And you may know that there are two, you may not know, there are two types of incontinence briefs that people wear. One is the type that pull up, that you resemble a regular underwear. The other type is the kind that fastens at the side. Really does look like a diaper. And of course, we've heard people refer to them as adult diapers. Well, at Pace, at that time, we had an overstock of the type that close at the side as we were ordering the type that you pull up. And she received a batch of those from our home care services. She was immediately triggered into her childhood abuse, which, without going into any detail, involved feces. She was immediately triggered. And in fact, so much so that she hid all the knives in her apartment to ensure she would not cut herself. She came to the session crying, and when I finally got to the root of it and figured it out from her that that's what had happened, I asked if I could advocate for her and go to our home care manager, and without disclosing anything about her trauma that I knew, to just advocate that she needed to have the other type of incontinence briefs. And she agreed, and I did, and she got the new kind, and she was fine. She was fine. Now that's a success story. But what occurred to me at that time was that how many people have we missed? How many people do not have a therapist that we had inadvertently triggered around trauma because of that very benign act that brought that person to a place of being infantilized and being triggered into a trauma? That's how, one, we have to understand trauma. We have to recognize that impact on that person, right? Most of us, my home care agency, even myself, wouldn't have thought, oh, this is a problem. We would have never considered that. The impact it had on her to the point that she was hiding her knives. Putting that knowledge into practice, what I did was advocate for her. Let's change. We have to realize that this could be problematic for many of our participants, so that we don't re-traumatize people. In mental health, we unfortunately always ask the question, what is wrong with you? We pathologize behavior. We have an entire manual based on pathology called the DSM-5 now, Diagnostic Statistical Manual for Mental Health Disorders. So we always say, what's wrong with you? Trauma-informed approach requires us to shift this question now and say, what happened to you? Symptoms, rather than pathology, are now seen as adaptation to a traumatic event. And I'll talk more about why people do what they do in order to adapt. That we don't see it as a symptom, we see it as an adaptation. And thirdly, that healing happens in relationship. Now, do you have to be a therapist to be therapeutic? No. All of us can be therapeutic. And one of the things that I really want to highlight in this training too, for you to be thinking about, is we're talking about the care that we give to our clients, to our patients, to our participants. I want you to remember that while we're doing that, we also have to show this kind of approach with each other. Because if you understand the prevalence of trauma, you have to know that among us in this room, just in this room, there are a number of us who have also traumatic experiences in our lives. So being mindful that it goes beyond our care with our clients, it also is in our relationship with anybody, the person at the grocery store, your neighbor, your family member, your colleague. So I want to show you a quick video. Anybody here not know Brené Brown? Brené Brown? Brené Brown is a well-renowned sociologist who has done a lot of study and work around vulnerability. She became very well known from the TED stage. I don't know if any of you watch TED Talks, but you can Google her and see her give some really extraordinary talks. She's now written several books. And what she really talks about is vulnerability. And when we allow ourselves to be vulnerable, it's in that space that we can grow, that we can connect, that we can be creative. Problem is that none of us ever want to be vulnerable. Vulnerability can equate for many people weakness, right? So I want to show you a video in where she's talking about the difference between sympathy and empathy. Oh, dear. Okay, let's try this again. No? Oh, here we go. Well, I had it for a minute. Oh, okay, let's try it again. Okay. Oh, perfect. I'm good at some things, not everything.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you can climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. Yeah. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now. I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
I love that video. I love that video because how many of you, I really relate to it, one. When I first saw this video, I thought, oh my gosh, I say at least a lot. And when you say that, it invalidates what the person just told you, right? I am so aware now when I say at least, or when somebody says it to me. The other thing about that video is that talking is so helpful for people who have had trauma. Talking is actually helpful for any of us. And it turns out that we're not really good listeners. Have you ever been with a person where you've shared something and then they either try to one-up you? Right? Oh, I've had this awful day, and all of a sudden this person says, you have no idea. Now let me tell you about my day, right? And then all of a sudden it's about them. Or you've got to be able to talk to somebody who can relate to your experience and who you can trust. That there's confidentiality. There's been some really interesting research in primary care. And these researchers, they put recorders in primary care offices, and they tallied or recorded how often providers interrupted their patients. And on average, patients were interrupted after 8 seconds. 8 seconds. And when they further carved out those variables, they looked at differences in providers. So female providers waited a little bit longer than male providers, physicians. Interns and residents, fellows, they allowed more space than seasoned professionals. I actually presented that finding at a community meeting one time, and this provider stood up and she said, "But we can get so much done in 8 seconds." And I said, "You're missing the point." Yes, we can get a lot done in 8 seconds. And how many of you, including myself, has tried to get so much done in 8 seconds, right? We are on task with our clients, and unfortunately, in those tasks, we miss the relationship. We don't give people space to talk. If you ever want to try something cool, pair yourself up with somebody and give one person 5 minutes to talk about anything. Doesn't have to be anything emotionally salient. It can just be the weather, what they did at work. 5 minutes, and then reverse. You will be amazed at one, how awkward it is for you as a listener to let somebody go on for 5 minutes, and without stepping in to fix or comment or anything like that. And two, as the talker, what it feels like to have somebody just let you talk for 5 minutes. When I teach clinical skills to first-year doctoral and master level clinicians, we talk about power in the relationship. The minute you walk into a situation with your client, you already have the power in that relationship just by virtue of your role. You are in the power position. The number one way that we equalize the power in the relationship or the power in that room is that we shut up. When people talk and have the space to talk, we give them more power. And if you ever want to equalize the power in your relationship with a client, you have to stop talking. Now, there's always a fine balance there, right? How many of you in the room are social workers or case managers? Yeah, I'm talking to you, because that is really hard to do, right? You're doing an assessment, an intake, and there's a balance between letting the person talk and not letting the person go on and on and on, because you have to get things done. So finding the way to say, hey, this is really important. I see it's important, and we have things we have to do here. But acknowledging that and letting them have a few minutes to start is really, really important. It's key. It's critical. Anybody have a comment about what I've said so far? Something that you're just like dying to say? No? Okay. All right, so what do we know about the prevalence of trauma? First of all, trauma is defined as individual trauma resulting from an event or a series of events, a set of circumstances experienced, and experience is underlined because it is experienced differently for every individual. We can all be in the same situation and see it differently. You all know this by being in families. You can be raised by the same people, and I got a whole different experience than my sister did. I don't know how that happened, but I did. That event is experienced by an individual as physically or emotionally threatening, harmful of their life, and has lasting adverse effects on that person's functioning, their mental health, physical, social, emotional, and spiritual well-being. These are the types of traumas that are kind of categorized or put into these different categories. One, we have abuse. Most of you are very familiar, at least emotional, sexual, physical, domestic violence, witnessing of violence, bullying, cyberbullying, and institutional abuse. The second category is loss. That can be death, abandonment, neglect, separation, a natural disaster, accidents, terrorism, war. That's under loss. And then the third, which I think is the category that often gets overlooked by us, are chronic stressors such as poverty, racism, invasive medical procedures. I sometimes work with women who have had, for example, a woman who's had an emergency hysterectomy, who always wanted to have children. And while there are other options, that is a very traumatic experience for that person to know that they can't have children. Maybe an amputation. Community trauma. In my own community, when we experienced two very close subsequent fires, the Waldo Canyon fire, the Black Forest fire, it impacted us at that community level of trauma. Historical trauma, slavery, Holocaust, Native Americans, family member with substance abuse, living with a family member with substance abuse, and I would also add here, living with a family member with serious mental illness can be very traumatic. Exposure is ubiquitous. 7 out of 10 respondents on a survey worldwide, and 9 out of 10 in the US reported experiencing one or more lifetime trauma. A couple of other statistics that I think are important to note. 13% of children in the US will experience confirmed case of abuse or neglect by age 18. That's a small number for those of you who have worked in child protective services or with any children. And of course, these are substantiated cases. 3.5 to 10 million people witness violence against their mother every year. 1 in 4 girls and 1 in 6 boys are sexually abused before their adulthood. 84% of mental health clients have a history of trauma. 50% of female, quarter of male clients experience sexual assault in adulthood. There's also this comorbidity of substance use and trauma. Up to 65% of all clients in a substance abuse treatment reported childhood abuse, and 75% of women in substance abuse treatment reported trauma history as well. 92% of homeless mothers have severe history of trauma. They are twice as much likely to have drug and alcohol rates and dependency rates compared to those without. And almost a third of all veterans seeking treatment have a PTSD diagnosis as well. So what is the impact now? Now we kind of understand prevalence. What's the impact of trauma, knowing that it's individualized? This is a lot of words, don't pay attention. You'll just have it on the slide for future reference. But one of the largest studies that came out of the CDC, a collaboration between the CDC and Kaiser Permanente, they surveyed about 17,000 insured individuals and asked them to respond to questions about childhood adverse experiences. And here's what they found. First of all, they identified through those focus groups, through their research, these are the types of experiences that people endorsed having in their lives. Physical, sexual, emotional. I've got physical twice. I've never noticed that before. Well, it's big. Emotional neglect, mother treated violently, household substance abuse and mental illness, parental separation, divorce, or incarcerated household member. They developed out of this a measure called the ACE measure, Adverse Childhood Experience. Anybody in here use the ACE measure in their work or has? Okay, you have. This is used a lot in a lot of different clinical settings, and it's really important now as we understand abuse throughout the lifetime and what the trajectory of the impact of abuse on individuals. What's interesting here, and we don't need to go through this entire slide, but when people, I thought I had a pointer. Do I? Oh, you can barely see it. When people endorse 4 or more adverse childhood experiences, women percentile was far higher than men. Total percent was 12.5% endorsed having that many adverse childhood experiences out of that study of 17,000 people. But some of the bigger, I think, implications from that study are what is the experience of, or what is the impact of trauma on people's health behaviors? And here's what we find. When people have 0 ACE score, no adverse child experiences compared to those who endorse 7 or more, look what happens in these areas of lifestyle factors. 1 in 16 smoke is now increased to 1 in 6. 1 in 69 have alcohol problems to 1 in 6. 1 in 480 uses IV drugs to 1 in 30. Heart disease goes up 1 in 6. And attempted suicide, this is staggering to me, statistics. 1 in 96, if you have 7 or more, that goes up to 1 in 5 attempts suicide. Now, when you think about our older population, older white males have the highest prevalence of suicide. Actually, older white males over the age of 65, but even more than that, white males over the age of 85 have the highest rates of prevalency in suicide. So if we think about the long-term impact of trauma and the cumulative effect of trauma, and we'll talk about that too, how that impacts a person's life. The other types of behaviors or manifestations of trauma that we see are also listed here. Depression, financial stress, risk of intimate partner violence, sexually transmitted diseases, unattended pregnancy, adolescent pregnancy, risk for sexual violence, poor academic achievement. And that's not an exhaustive list. There's much more. So we know what that looks like in terms of health behavior. But the other thing that we have to understand is how does it impact the brain? There's a great book, if you ever want to look at kind of the neuroscience around trauma, and it's called How the Body Keeps the Score. And it really is about how our bodies take in trauma and what our bodies do with that, both at the cognitive level, the brain level, but then also in our own health-related behavior. So here's how I want to explain this slide. Our brains follow a regular path of neurodevelopment. So here's what a PhD will get you. This is your brain. I have no other better way of explaining it. You can consider that this is your brain stem. And we develop from the brain stem forward. Right here is our frontal lobes. Frontal lobes are the last to develop in our brains. The brainstem is responsible for our basic breathing, respiratory function. And then we get into higher types of cognitive processes, including language and memory and emotion and motor development. And then finally, our executive functioning, which is the most complex of all of the cognitive functions. So what happens is that as our brain is developing as it normally should, biologically, if we have a traumatic experience that happens between birth and really the age of 26, which is when our brains fully develop, the frontal lobes are the last ones to develop. So anytime in between that, we have a traumatic experience, it interrupts the normal cognitive development of our brain. That is the nature-nurture argument that all of you have heard, right? It takes the interaction of both of those things impacts us as human beings. So on this, hierarchy, you see that you have, from conception to death, an adverse childhood experience disrupts our normal neurocognitive development, then leads to poor social, emotional, and cognitive functioning, leading to an adoption of health risk behavior as an adaptation to the trauma, leading then to disability, disease, social problems, and ultimately early premorbid death. Premature death, rather. So the brain has that bottom-up organization. Our experiences build upon that architecture of our brain. The fear activates an important part of our brain, which is the amygdala. And what's interesting about the brain is there's two structures that sit side by side. One is the hippocampus. The hippocampus is responsible for the consolidation of short-term memory into long-term memory. It sits right next to our amygdala, which is our fear center, which is part of our limbic system. So, when I have a memory of a trauma, it elicits an associated fear. It's also closely related to our senses. So, let's say in my community where we had fires, there's a trauma response that happens when people smell smoke. They smell smoke and they are immediately triggered by a memory of a fire that created fear, right? So but you can also have positive experiences. When I smell apple pie, I think of baking pie in the kitchen with my grandmother. So it works both ways. The effect of trauma on the individual can be conceptualized as an adaptation or a normal response to a very abnormal situation. Most of you in here have heard of the fight, flight, or freeze response. We typically talk about this process from a biological perspective. We typically talk about this in terms of the sympathetic nervous system, that it's our body's natural reaction to a threat. But that information has been now transferred or has been applied to how we think about trauma, how we think about the behavior of other people. So when people are struggling to regain or hold on to their own personal power, we label them as non-compliant or combative, when actually what they're doing is they're fighting for their personal power. When people disengage or withdraw from care, we label them as treatment resistant or uncooperative. And when people give in to power, I call this the bobblehead effect. You've had those clients who are like, yes, I'll do whatever. And then as soon as you're out of there, they're back to doing whatever they had no intention of doing, but they just needed you to get out of their face, right? We call those folks passive or unmotivated. So the way I want you to think about this, and I think this is probably one of the most important slides in this presentation, is because we see that behavior and we label it something, but what we need to think about is what is causing that behavior, and this person somehow is feeling threatened. They are fighting us because they don't feel safe in this situation. And it could be anything from, how many of you here work in long-term care? Anyone? Okay. When we work in long-term care and a resident doesn't want to go to dinner at the prescribed time that dinner is served. They don't want to have their bath at the time that they're supposed to have their bath, and so they fight against that. Staff get very upset, they get irritated about that, and what we have to understand is what about that situation feels unsafe for people? What about that is that person struggling to regain some kind of power, right? And for people who've had trauma, they've been victimized at a point of vulnerability, and usually somebody that they trusted, typically a caregiver. So this training is so important when we're working in long-term care because it comes up a lot. I often think about how one of the unsafe things, I guess, that we do in long-term care is that folks who are on Medicaid, if you're on Medicaid and you have to go into a nursing home, the likelihood of you getting a private room is zilch, right? Yeah, it doesn't happen. And people who are on Medicaid, and I don't know if there's any research on this, but in my own experiences of being a clinician over the past 12 years, is that a lot of people who are on Medicaid have a trauma history. And you put a person into a situation where they don't know that person, they have no personal space, that it's unpredictable. You can imagine how stressful that is. And when you think about the fight, flight, or freeze reactions of people, you know, staff are very quick to what's going on? What's the problem? Trying to fix it without kind of really understanding this is a reaction to not feeling safe. What do we need to do? And there's really no fix for people who are on Medicaid who have to go into these places and have to share a room. But could we approach them in a different way? So the impact of trauma has both long and short-lasting effects. It affects a person's coping response, their relationship, their developmental tasks across the lifespan. It impacts their physiological responses, their well-being, social relationships, spiritual beliefs. I will hear from people who are going through a current trauma or have been through trauma and will say things like, "Where is God now? God has left me. No God would allow this to happen. I didn't deserve it." And the number one thing that you can say to a person with trauma is to say, "You didn't deserve it. That shouldn't have happened to you." And again, it's happened to them. They didn't ask for it, they didn't deserve it, and that it can be such a healing reaction to a person to hear that. Behaviorally, we see people blow up when they're being corrected or fighting when they're criticized or teased. This used to come up a lot and I didn't realize it at the time, but when I worked at PACE, we'd have a lot of bullying that occurred in the common eating dining room. We see this happen in nursing homes and assisted living, any kind of communal dining space, where people start becoming territorial over their space, where they eat, and people are bullied. And when you think about bullying, that follows somebody from childhood. If people were bullied as a child, I mean, none of us got out of junior high unscathed, I don't think. That follows you into older age and in these situations where you're now ostracized from the group. You're not part of the cool kids. We see reckless or self-destructive behavior, frequently seeking attention, or reverting to younger behaviors. On the emotional side, nightmares, problems with sleep, sensitivity to noise or light even, being touched. So here's an example. That's that woman that I talked to you about at the beginning, who, with the incontinence briefs. Same woman, at one point in our therapy, she came to the session and she was wearing a kind of a half sleeve shirt, and exposed under her sleeve was a big bruise. And it actually was kind of like a skin tear. And this happens a lot with aging skin. We all know that. And so I just absent-mindedly reached over to her to ask about what had happened. And I touched her, and she flinched and drew back her arm. And I thought, uh-oh, something's there. Oh gosh. And at that time, I wasn't quite sure what to do in the moment. She changed the subject quickly. I went that direction with her. Even therapists avoid, I'll just say. And I thought, oh, okay, I'm not sure what that was about. So I waited. The next session, she came back, and she said, she's so courageous, this woman. She's now deceased, but she just had so much courage in therapy. And she said, you touched me, and, I flinched. And I said, yeah, I did notice. And she said, well, when you touched me, it reminded me of when I was on the inpatient psych unit when I was in my 20s, and I was cutting. And the therapist, before every session, made me pull up my sleeves to see if I had cut. And it was very shaming to me. And she said, and when you touched me there, I thought you were inferring I had been cutting myself. Totally benign thing that I did there. And yet, right like that, triggered her to think that I was inferring that she was cutting herself. So that those small little hypersensitivities that are so overlooked by us, I could have just glossed over it too. And actually, if she'd not been as courageous, I wonder what I would have done. I mean, hindsight's 20/20, but would I have followed up? Would I have said, hey, I noticed that you did that? Did something happen? Being aware is the best thing we can do. Be aware. Don't be afraid to comment on it. Feeling sad, angry, emotional swings, unexplained medical problems, idiopathic pain. Confusing what is safe with what is dangerous, not knowing what is safe and what is not safe. Trouble focusing or concentrating, can't imagine the future. Other things that we look for, irritability, excessive watchfulness can look like paranoia, sadness, shame, flashbacks, sensitivity to being touched. Some key factors here to remember is that it happened early on in a lot of cases, and we'll talk about the accumulation effect. Usually you don't have just one trauma, you've got multiple traumas. Have any of you ever been to a funeral? This happened to me recently. I was at a funeral for somebody who I knew the family, but wasn't particularly close to this person who had deceased. But I went as a sign of respect for the family. And as I'm sitting there, I start bawling uncontrollably. Why? Because then I remembered my sister's death a few years ago. And so it's that accumulation effect, right? We have an event, it's completely unrelated to those events, but it triggers us in that. So there's an early occurrence. The person is used to being silenced or not believed in their story. Blaming or shaming, and knowing that usually the perpetrator was a trusted caregiver, especially when it happens early in life. So how do we practice trauma-informed care? So we now know what the prevalence is. We now know the impact on individuals. Now we got to put it into practice. And in that practice, we seek to actively resist re-traumatizing our clients. So we'll make two different distinctions here. One is trauma-informed care. That takes into account that knowledge about trauma and all the aspects of service delivery. And in trauma-informed care, you don't become trauma-informed when you clock in the morning. You breathe it. It is a philosophy of life. It is not something that just, okay, now I'm at work, now I'm going to be trauma-informed. No. It is something you have to embody in every single interaction that you have with people, everywhere that you go. It's not specifically designed to treat the symptoms of trauma or syndromes related to trauma, and it really is an organizational effort in providing care that recognizes and takes into account that the possibility of trauma is there in your participants or your patients or your client's history. You don't have to ask about it. You don't have to know about it. You assume it. And in this case, when we assume that people have trauma, we will approach them differently. We don't have to know all the gory details. And that is very different from trauma-specific care. Are there any mental health professionals in the audience? Oh, my peeps. Okay, so any of you here that are mental health professionals, do you do trauma in specific care, such as EMDR or cognitive processing therapy? Anybody? Okay. Prolonged exposure. You do EMDR. Okay, great. So trauma-specific care is really evidence-based treatment to alleviate the symptoms of trauma. It is really to help facilitate the recovery of trauma, from trauma, and it directly addresses the impact of trauma on that individual. You should know, as an agency, as an individual provider, who those people are in your community who provide trauma-specific care. Because when you come up against this with your client, you need to be able to say, there's help for you. Let me get you in touch with somebody. Let me help facilitate that. I work in trauma-informed all the time, and I definitely work with trauma in my practice, but I don't do trauma-specific. I'm not EMDR certified. I don't do prolonged exposure. I don't do cognitive processing therapy, but I know who my colleagues are. And so I can still see that individual and refer them to somebody who does that work and see them simultaneously while they're doing that. That can work. But you should know who those folks are in your community so that you can refer people appropriately. There was a group that came together of trauma survivors and researchers, and they did some focus groups where they asked trauma survivors, what do you want professionals to know in working with you? What are the core principles of trauma-informed care, and what do professionals need to do individually to become more informed? What do they need to do with themselves? As we work in the service delivery sectors of healthcare, we have to hold up the mirror. I never ask a client to do anything I wouldn't be willing. And that requires us all the time to hold up the mirror and do self-reflection. So for the next hour, I'm going to spend time focused on what are the principles of trauma-informed care that you can take back to your agencies. And then what are the things you need to do individually to hone in your own skill for helping your clients. Does anybody want to say anything at this point? Anything standing out? Comments? Questions? Objections?
I did have a question.
Yeah.
I forgot it, but I remembered it. When we were looking at the pyramid,
Yes.
at the top it said that it's one of the, I guess, results of trauma is early death. Where did that data come from, and what would the age be considered as early death? What age would that be?
Right. So that came from the CDC and Kaiser Permanente study, and they tracked people longitudinally. And so early death can be a number of things. I mean, they're kind of encapsulating it in that broad definition, but it could be death due to lung cancer, which is associated with increased smoking. It could be death due to renal failure. It could be suicide. So there are multiple things, and if you want, and I've included the citations, so please feel free to go back and read the literature on it. The other question is, what is early death? So what researchers do is they look at what normal aging process is for our aging bodies, and at what point is our life expectancy. So right now, life expectancy overall is, I think, 78.1 for our human race. For males, it's 76.1 years, and for females, it's 81.1 years. So they compare when people die based on these lifestyle behaviors and compare that to what is the normal lifespan right now. Does that help? Yes. Okay. There was a gentleman in the back that had a question.
As you discuss the evidence of success with the person-centered, I wanted to ask, do you have any sort of context or filter that you hold it with when working with someone with maybe bipolar or schizophrenia? And yeah, I'll leave that open-ended there. But like, is there the same exact measurements, because interactions and experiences can be very different for some in those histories or diagnoses?
Let me see if I'm understanding the question. So is there anything different we would do with certain diagnoses still using trauma-informed care?
Yeah.
Is that what you mean?
Yeah, so trauma-informed care, but in the early discussion we had with
About person-centered?
Yeah, person-centered. And the evidence was, interaction was, you know, the engagement.
Yeah.
And I've worked with some where, you know, engagement waxes and wanes, it changes. And I may not be doing anything differently, but they are in a different place in that time. So how do you hold that in context?
Exactly. I mean, so we have to take into consideration everything that's going on with that individual, whether it is active psychosis, such as mania, such as internal command hallucinations associated with schizophrenia, but it could also be dementia, it could also be delirium, a deep depression, it could be medication interaction, right? It could be dehydration, it could be sleep deprivation. Anything that is going on with that individual is going to impact our interactions with them. And we have to be the surveyors of what's happening with them. What is their capacity to be in a relationship even in this moment with us? And so I think that the principle of trauma-informed care is that we want to balance out the power. We want to give people a space to talk, even if they're in a psychosis or an altered state. We also know that if something is interfering with that, that's not so much trauma maybe, but is a function of their current state, that then we have to pause and get that figured out, right? We got to get that worked out. And that can be really challenging, especially when those behaviors waxes and wanes from one moment to the other. This can be particularly challenging. Sometimes it can be remedied pretty quickly when you're talking about psychiatric disorders, such as mania or depression or psychosis. You know, once we get medication on board and the person can be engaged with their medication treatment, we can get a better relationship going with them. In the meanwhile, I think just holding on to those core principles of engagement is really important. And also that sometimes we have to be the surveyors of that person in their environment. I'm a big proponent of person-environment fit. And if I may, let's talk about that real quick, because I think that is person-centered care, and it also applies to this conversation. I'm glad that you brought up that question. Unfortunately, I don't have something to draw on, but if you can just bear with me and think about a diagram where you have a Y and X axis, okay? It looks like this. And on the Y axis, you have capacity. And when I mean capacity, I mean a person's mental functioning in that moment. You've got from low at the bottom to high capacity. On the x-axis, you have what we call, on this continuum, environmental press. And what that it means is stimulation in our environment. Okay, so you have on that continuum low at the intersection of the x and y, low to high. So you have low press, low capacity, high capacity. What we have to do as providers is find what we call the zone of maximal functioning. And what that looks like is if you were to draw a line from that corner kind of up, and there's this kind of band, that's the zone of maximal functioning. What does that mean? That's Goldilocks. That's our sweet spot, right? When a person is incapacitated, and I don't mean that by the legal term, I mean it clinically. Like when a person is at low capacity, we have to be the ones to figure out where their capacity is in this moment and what's the press on the environment. Let me give you two real-world examples that applies to us. So have you ever been at the grocery store? Let's say it's 5 o'clock on a Friday night, and no, it's 4:45. 4:45 on a Friday night. You're packing stuff up and your phone rings, and you're like, oh God, I have to pick that up. You pick it up and you're hoping, you're praying it's your colleague saying, we're still on for margaritas, right? And it's not. It's a client in crisis who needs your attention right now. Do you have a space in your basement? I need to come live with you. Okay, so you're involved. Then you get the documentation that involves you another. So there you are, 6 o'clock, 6:15. You're finally packing up. You get in your car and your partner calls you, hey honey, what's up for dinner tonight? I didn't plan anything. Can you run by the store? Yes, I will go by the store. Okay. You get to the store, you get your stuff, you're standing in line, and what's in front of you, right? Well, number one, there are 2 checkers at the grocery store on a Friday night. 2. Why is that? I don't know. I've asked myself this question over and over again. 2 checkers, you have a long line, you've got people with coupons, you have people with screaming kids. It's just hell on earth, right? And you've seen people, you may have been that person, who loses it in line, right? I mean, I'm not on Planet Pluto here, right? You've seen it, you've done it, where people will, they'll do this kind of thing. They'll kind of slam stuff. They might be on their phone. You won't freaking believe my life. They're just losing it. Okay, this is an example where your capacity at 6:30 on a Friday is low. The environmental press is high. In these spots, outside of that zone of maximizing, what did I say, maximal functioning? Outside of that zone is where what we call maladaptive behaviors, or acting badly. Okay, so that's an example of when people act badly. Low capacity, high environmental press. Now let me give you the opposite situation. Let's say last night you had that extra glass of wine, maybe 3, and you know, because you're all very intelligent, that alcohol really doesn't promote sleep, it interrupts sleep, but we do it anyway. So you had that extra glass, you had interrupted sleep, you didn't get to the gym because you got that kind of headache this morning, and let me give you a different one. Well, that's a good one too. So let's say, again, you're at Starbucks and then people are losing it, right? Same type of thing. Low capacity, right? Because you didn't sleep. So you have to think about those variables. But let's say you did the opposite. Let's say last night you were like, you know what, I learned my lesson last week. I'm going to go for soda water tonight. I'm going to get a good night's sleep, and I'm going to get to the gym because, by God, it's the middle of February, and I swore that I would stay committed to my goals for the resolution for the new year. So you get up this morning, you go to the gym, you feel good, you get ready to come to this training because you're like, hey, I'm going to learn something new, and I got out of the office for a couple hours, bonus. And so you come here, and then you get here, and I, as the presenter, am just reading monologue after monologue. And I'm just practice 6 core principles of trauma-informed care. I'm reading from the slides. I'm not looking at you. What happens here? Maladaptive behavior. This is where people start texting. This is where people start rolling their eyes. This is where people get up and leave. All kinds of things happen. That's because your capacity was high when you got here, and I didn't engage you. So the environmental press way too low. So you see how that happens just to us, right? You think about a person who, let's say a client who is up every 2 hours because of their incontinence or bladder urgency, who has multiple medications, who has pain, who didn't get a bath this morning, or who somebody yelled at them, or who has dementia. And now we have to figure out, how do we, based on what their capacity is in this moment, what do we do to change the environment for that person? Here's an example. When I worked on a subacute short-term unit at the Palo Alto VA, and there was this gentleman there that he had dementia, and he was raging against staff, throwing things, screaming at them, and I observed him. I walked around and watched the environment. I was just observing him in his space. And what I noticed was on the television in the main room, in the sitting area, they were showing old westerns, shoot 'em up kinds of stuff. And I thought, wait a minute, why are we doing this? Because he couldn't articulate to me that he was overly stimulated. But he was overly stimulated, and he didn't have the capacity to take that in. So he responded in his behavior, throwing things, yelling at staff. I recently was working on a nursing home unit, memory care, where I was helping staff come up with some modifications to the environment. And one of the things that we were sitting in the administrator's office that's right in the unit, and it was Halloween, and they were playing Grease, the theme from Grease, for those of you who know Grease. And they had it real loud, because of course people are hard of hearing, so they have it very loud. And all of a sudden this man who has dementia started coming into the administrator's office. We're sitting there, and he's coming in, and the CNA is chasing after him. Mr. So-and-so, come on now, you need to come back here. And he's just making himself into the room. And he can't speak, he's nonverbal in his dementia disease process. And I say to the CNA, wait, look what's happening. He is escaping. Why is he escaping? Let's think about this. Oh, we have the music too loud. He needs to be quiet. Exactly. Where can we get him to a quiet space? This is so important. And you may think that this is a deviation from trauma-informed care, but it's not. Why? Because that person can't tell us what's going on. The person who is in the middle of a manic episode cannot tell us what's going on because they're feeling so damn good right now. I am partying, I am having a great time. And they're like, no, no. Let's help you de-stimulate a little bit. Let's get some calming stuff going on. So we have to be the surveyors of that, and we have to be the ones to change things up because sometimes people can't tell us. Does that make sense to you? Is it helpful to know that in your own practice? Maybe a couple? It changes the way I think about everything. When I'm in the grocery store and I'm either that person about to lose it or I see other people, one thing that the person who is incapacitated can't do is they can't modulate their behavior. We can do that. I can say, okay, take a deep breath, this too shall pass, I've got coping strategies. Or when I'm understimulated but have high capacity, I could say, okay, just throw yourself into it, this will be over soon. We have ways to do that, but other people do not have ways to do that. So we have to do it. We have to figure it out. There are 6 principles of trauma-informed care. Understanding.
Dr. Gibson, we have a question
Oh,
up here.
I'm sorry, yeah.
Yeah, so a big part of like person-centered thinking and person-centered care is the client decides what they want to go for and how they want to go for it. But that also means that at times you have to accept that goals that the client has laid out,
Right.
that they have worked towards and completed like 90% of, if they don't feel like completing the last 10% to get what they want, they're not gonna, they can come so close but not get it. I guess I'm asking that as a direct service provider, how do you accept when a client says they want something, they've done most of the work towards it, but they're unwilling to do that last part, and it's just out of your control and it's their choice?
Oh, that is the million-dollar question. And what I will say is that every person, a couple things that you can do. Every person deserves to make the decision and have an informed risk decision, right? So by that, to say, okay, I'm just going to lay it out for you. You've done so much work up to here. There's this little part left. There's something in you that must not, somehow, you're not ready for it. You don't want to do it. It's scary to you. There's all kinds of reasons why that could be. If you don't do it, these are the possible outcomes to you. I will support that decision. I don't have to like it, but in support of you, I will support that decision. You just have to know what the risks are of that choice. Unless that person has been deemed to be incapacitated by a court, and they've lost their rights, that's different. That's a whole different conversation. But even then, the person should be voicing their preferences, and their values should always be at the forefront of our decisions as surrogate decision makers. But when that person has that ability, and when they've gone so far, this is at the crux of addiction treatment. Relapse, it happens for all of us. We get so far in our health goals. I'm right at that point where I've lost 7 pounds. I just need to do 3 more, and you know what? Screw it. I'm done. I got this far. It's fine. We all do it. We relapse over and over again. So relapse is part of our normal behavior. So I think the way that I address that is that, again, one, you have to first say what the strengths of that individual is. Wow, you've really done a great job. You came this far. It seems like something's holding you back now. If you want to talk about that, let's talk about what's holding you back. If you don't complete this part, these are things that will happen. You've been there before. You know what is going to happen. You still want to make this decision? Okay. You know, sometimes I remember at PACE, we'd have somebody come in to PACE and they'd say, well, I'm enrolling because I want to control my diabetes, I want to be able to come and get a free meal every day, and I'd like to get some PT. Okay, fine. 3 months later, that person has stopped accepting home care services to check their INR. They stopped coming to their appointments. They're canceling their day center days. They're not engaging in activities with rec therapy. They stopped their physical therapy. All of a sudden, they're not engaged. So what we have to do is ask the person, you know, when you came in, these are the things that you said you wanted. We're seeing that that's not happening. Have your goals changed and we haven't caught up to that? And sometimes a person will say, yeah, you know what, I'm really depressed. It's the anniversary of my husband's death. I don't give a crap right now about my diabetes. I don't care about anything. But we have to ask the question. We have to say it and ask, what's happening here? If they want to make that decision to not manage their diabetes, that's okay. All right, then let's not beat our heads against the wall, because I'm feeling frustrated as a provider. I'm nagging you. We're spending resources to come see you all the time and you don't want to do it. If it's depression, then let's treat the depression. But it all starts with the conversation. And when you have a relationship with that person, let me tell you, that conversation can become easier and easier. And in some respects, it can be seamless. It can be effortless to have that conversation. We have to step out of our own judgment, right? It can be so frustrating. I get it. I work with I worked with a couple for an entire year on their marriage. Saw them every single week. And on the last session, as I was leaving my postdoc fellowship and I was terminating their care, you know what the woman says to me? Well, if he hadn't had that affair 20 years ago, what? This never came up. 52 sessions? Never once. Yeah, you know, people make choices. It doesn't mean I'm a crappy therapist. It doesn't mean the relationship was wrong. It doesn't mean I didn't connect. It meant that they're not ready. And I said, and as I kind of gained my composure, I said, well, it sounds like you're ready for a next chapter of work. It's not going to involve me, but best of luck. All right. Is that helpful to you in the back? Okay. All right, 6 core principles. We're going to have to fly through it because we only got 35 minutes. But these slides are available to you, so you can access any of this. Oh, we have construction. Okay. If anyone's having a trauma response right now, please feel free to leave the room. Okay. The 6 core principles: understanding, safety, trustworthiness and transparency, choice, which we've touched on, collaboration and mutuality, and empowerment. You can all read these, but we have to understand, again, that trauma and stress go hand in hand. And we can act compassionately towards people, take very well-informed steps towards their healing and wellness. We can move past cultural stereotypes about what is normal responses for people and not normal, based on our own biases and cultural frameworks. And we can leverage the healing through traditional cultural connections, recognize and address historical trauma. Recognize that I am different from you. When I work with immigrants, refugees, people of other ethnicities than my own, I'm very aware of the impact of that relationship. There's a great video that I share with when I teach forensic interviewing of older victims to law enforcement, social service workers. And there's this video of a white male social worker in an older African woman's home. And he's interviewing her. And I ask the audience always to talk about how does this dynamic, just gender and race, have to do with the relationship? What impact does that have? We have to understand that, and we can address it with people. We can say that openly. How is it for you to work with me? When I work with students, they're 24-year-old, and all of us have been there. You're young, you walk in to work with an 85-year-old woman who says, "What the hell do you know?" You know nothing. And so we have a conversation about that. Safety is really important. People need to feel safe both physically and psychologically. Now, when I first saw this slide and read it for the first time or put it together, I thought, well, that's duh. Of course, safety is, we all want to be safe. But let me talk about safety in a different way. There was a study done where researchers went into an inpatient psychiatry hospital. Anybody work on inpatient psychiatry or been there? Yeah. It's like the least healing situation ever, right? And what this researcher did is they asked patients and staff, one, do you feel safe here? And how do you feel safe or unsafe? And what they found out, not surprisingly, is that the two groups had very different reports. Staff said, yeah, I feel really safe. We just got this new weighted furniture. Now the patients can't throw it at us. I feel safe because now we have a plexiglass up in front of the nurses' station. Thank you, whoever said that. Thanks for, I got word finding difficulties. Who, now the patients can't throw things at us. Now we have our space. We can get our work done. They don't come into our space. Yes, I feel really safe. I can press this button and a team comes in, crisis response team, and gives them the shot of Haldol and we're good. I feel great. What do you think patients said? Hell no, I don't feel safe here. I'm in a place with a bunch of crazy people. I have people screaming, people throwing their feces. I can't even have shoelaces on my shoes. I can't have a phone. I can't reach out to anybody in my family, my friends. I can't go up to the nurses' station because they got this plexiglass there. I see this crisis team run in with shots of Haldol and restraining people. I'm scared to death. This place is not safe. So we have to understand in our organizations or where we work, in the clinical situations in which we serve people, what is our perception of safety and what is that person's perception of safety? And when you know what we know about trauma already is that persons with trauma histories or currently in trauma cannot distinguish between safe and unsafe. This couldn't be more evident than families and practitioners who say, we're ready for Miss Smith to go into long-term care because it's a safe thing for her. She's had one too many falls. This will be a safer placement for her. It's not safe to Miss Smith. And for a lot of people, it doesn't feel safe. So we have to think about the interventions that we do to promote safety. What we think is safe may not feel safe to that individual. How do we understand that? And particularly, how do we understand that when we see behaviors that suggest otherwise? How do we create safe spots? Or how do we create the relationship where people can talk about not feeling safe? Trustworthiness and transparency is really important. You have to tell people what you're going to do. We know our work, but our clients don't know our work. They don't know what happens next. I talk a lot about this with persons who work for Adult Protective Services. You know, there's a lot of steps and things that have to get done. And we have to be better at informing people about the process. When I file a report with APS, I am transparent about that. I don't want to surprise anybody. I want to engage them in that process. Let them know this is what I'm doing, this is why I'm doing it, and this is when I'm going to do it, this is what's going to happen. This is what you should expect next. We have to do that because it shows our authenticity when we're transparent. I think transparency is even more important when we make mistakes. We do not talk about our errors enough. We don't let people see that we are human, that we make the mistakes. We don't acknowledge it, we don't take responsibility for it. And you have to do that. If you're going to build trust with a person, especially somebody with trauma, you must accept responsibility. You have to be transparent, and you have to gain their trust. It's okay if you make a mistake. It's when you try to cover it up, that's where it bites you. We've probably all been there. People's strengths need to be recognized and built upon. This is what I love about working in geriatrics. People come to us with so much knowledge. They know everything. I love working with mental illness, serious mental illness in older adults. They have been through it all. They know their symptoms. They get it. And we can build on that. Even if it's not mental illness, what got you through the tough times? And how does that translate to now? You've been through a lot in your life. What part of that was your strength, and where do we use that now? What was it? Was it prayer? Was it your family? Whatever that was, build upon their strength. What got you through it? It fosters a belief in resilience, not only for when we can talk about it within an organization at the system level, but with the person. I spend a lot of time talking about a person's strengths and finding out what their strengths are, applauding their strengths, recognizing, noticing when they do good, catching people at doing good is really important. Collaboration is vital. You have to have meaningful sharing of power in decision making, even when the decision is not one that you want for the client. Even when it's not that. I mean, I think it's interesting about this delicate balance between empowering a person to resolve what they want and what they need. Those can be, what we want isn't exactly what we need, right? I wanted to be a Dallas Cowboy cheerleader with, you cannot believe how much I wanted that. I just am not built for it. And it's not really what I needed. And so helping people understand that it's okay to want this thing. Is it what you really need right now? Empowering people. I've always talked about this, didn't I? Seems like this is new. I don't know. Enhancing your collaboration. Maximizing empowerment, a sense of empowerment. Again, I think it's about commenting on people's strengths and their resilience. Empowerment can also happen through peer support. And I'm not going to spend any time on this because it's unfortunate we don't have, for trauma victims, or trauma survivors, really, is that we don't have a peer support group. Peer support really looks like AA or AN. We just don't, to my knowledge, in our communities, we don't have this. And we certainly don't have it for older adults. So this kind of encapsulates what we've talked about here. In the center is the relationship, but outside of that are all these other things. Understanding the prevalence and impact of trauma, promoting people's safety, earning their trust, embracing the diversity of experience and of culture, provide holistic care that addresses the whole being, respect human rights, pursue that person's strengths, choice, and autonomy, share the power, communicate with compassion. All of that is about what we do in relationship with that person. So what are the things that you have to do to be better skilled at that? It's all this stuff. That's a lot. I'm going to kind of fly through it a little bit, but I want you to spend some time with these slides when they are published, because I think it's really important, if not critical, to you being the best provider you can be. You have repeated opportunity to offer a corrective emotional experience. So here's how I've laid out these slides. These are I statements. You have to know when you're feeling certain things, tired, angry, sad, frightened. And you've got to be able to read the nonverbal cues, emotional cues, facial expressions of other people. Their tone, the intonation, their movement, rate of voice, rhythm. Understand those nonverbals and know and ask about it. Be brave. Be brave. When I saw you do this, can you just tell me what that is? When people cry and unravel in front of me, I ask them if they can put words to their tears. Can you put words to this? Know that you're able to verbally reflect somebody else's emotional state. It sounds like you're feeling very angry. After you reflect it, you want to validate it. You had to wait 3 days for me to return your call. Your question was very important to you. I understand why you're mad about this. You don't have to condone, and you do have to set limits. When people say, call you names, I understand you're angry, and it's not okay for you to call me a name. If you want to take a few minutes, we can have this conversation again. I really want to understand what's going on with you. Regulating feelings is really challenging for a person who's being triggered or who's had trauma. Emotional dysregulation runs rampant in persons that really struggle with that. Dementia can also undermine accessing the skills. And when a person is triggered, they sometimes disassociate and can't figure out how to get back in equilibrium. So we have to hone those skills. So know when you start feeling overwhelmed, how do you bring yourself back to emotional balance? So that you are equipped to engage with others who are experiencing those overwhelming feelings, help them manage their own feelings. Be aware of some grounding experiences. I think the best grounding experience is breathing, quite frankly. Because when people are panicked, they start breathing shallow, in a shallow way. And then they can faint, all kinds of stuff can happen. So what I'll do with people, if I'm in front of them, I will say, look at me and let's take a deep breath. I need you to take another deep breath. We do it together. But I also do it on the phone. I need you to take a deep breath with me on the phone. I want to hear you inhale. Okay, now do it again. Now exhale. Okay. We're having a grounding moment so the person can regulate again and come back to homeostasis. The other things you can do is, I keep peppermint candy in my office. Eating a peppermint, if you've never tried it, eating a peppermint really grounds you. Because when you breathe in that strong menthol smell, that aroma, it really brings you back to this moment. So I keep peppermint available. Keeping a rubber band on your wrist, to snap. There are lots of, you can Google it. Grounding exercises, know what they are so that you can help a person in that moment. Understand that stress response, the fight, flight, or freeze response. Understand that behaviors include fighting, running, shutting down. When you see those behaviors, that should be a red flag to you. This person doesn't feel safe. This person feels threatened. What's happening in this situation that's making them feel that way? One of the things that Adult Protective Services does that triggers people all the time is the unannounced visit. You got to do it. I get it. But that's a horrible thing, right? The unannounced visit. And they see all kinds of behaviors when that happens. Any number of these. You know, we just it happens on a daily basis. Identify what your typical response is to overwhelming stress. Catch yourself when you become overwhelmed so that you can provide others with that stress response. What we talked about, print that slide, or get a narrative in your own voice about how to explain that to a client. You'll be amazed at how people really connect with that and go, hey, that's what I'm doing. I was working with a brother-sister dyad who were involved in a legal battle over their mother's rights. And the daughter had a real hard time regulating. And she would fire off these horrible emails to the guardian ad litem that worked against her. And so I talked to her about this response system. And her brother had different responses. He shuts down and kind of does the bobblehead thing. And she fights. She comes out fighting. Both had trauma in their histories. And when she could hear it from that perspective, she could identify it when it was happening, and she would pump the brakes. Like, okay, give yourself 24 hours before you send that email with all caps in red letters. Not helpful. Know that the brain holds on to that information, and that there are it's survival based on memories that can lead to actions that doesn't even make sense. We see this a lot in rape survivors. They smell a cologne or they see a mustache, and then all of a sudden they are transported and cannot distinguish that this situation is not that situation. So know what your triggers are. We're all triggered by something in the work that we do. How can we not be triggered? Have a list of your triggers and develop some skills around that, a plan. Help you deal with those reactions. Be able to explain your triggers. Be able to explain the concept of triggers with your clients. Not your triggers, but the concept. And develop a plan for them to respond. Normalize it for them. It makes sense why you are feeling this way, given what I know about your history. It makes sense that you're feeling vulnerable and out of control, given what I know. How can you feel more in control right now? What do we need to do? Do we need to take a step back? And talk about those triggers, because that can be so helpful. When people come to therapy, the number one thing they want to know is, am I normal? Am I crazy? We need to let people know it's normal, it's okay, it's okay. The price of living through adversity means that people have numbness, anxiety, overwhelming feeling states that are sometimes out of their control, feels out of their control, flashbacks, nightmares. There are many problem behaviors, as we talked about, that are actually solutions to those feelings. People use drugs, drink, gamble, have promiscuous sex, overspend, binge watch TV. We do all kinds of things to escape that feeling, right? So some people use stimulants to upregulate, they use depressants to downregulate. You have to examine your own problem behaviors. What do you do? We all do it. And see how it might be viewed through a coping strategy rather than being self-judgmental. So think about your troubling behavior through that lens of curiosity. How does this behavior make sense? How might it serve this person? And what might have happened to them that makes this the logical and rational response? Many events that cause trauma are very stigmatizing for people. They were not believed. they were blamed for it. Or that others who knew that happened, they thought they would be judged as liable for it or to be damaged. Having one story heard by someone who's supportive and compassionate, willing to listen, can be a very healing experience. Now, what's important about that is that you have to know how much you can take on as a listener. Because another thing can happen if we're listening to people's trauma over and over again. It's called vicarious trauma. I've experienced that myself. And so we have to be very boundaried about that. You have to know where you end and the other person begins. You need to know that I have to take care of myself. I did something real stupid recently. I booked my schedule back-to-back clients. One right after the other, 7 one day. And at the end of my last session of the day, I had seen this woman's family earlier in the day. She comes to and after that session, she said, "Any chance you could see me at the end of your day?" "Yeah, no problem, come back." She comes back. I hadn't gone to the bathroom. I hadn't had a lunch break. I didn't do any of that. And she saw me. I must have been on me, but she said, "Did you even get lunch today?" I said, "No." "Do you have a snack?" I said, "Well, yeah." "Well, go get it." And I said, "No, I can't. I don't eat in front of clients." "You're going to eat," she said. And I thought, oh, God, the client's taking care of me. Oh, geez, I'm going to be turned into the board. You know what I mean? I was just like, and I realized that I was impaired at the end of the day. I was impaired. I mean, really. And so it taught me a valuable lesson. After that, I said, okay, I got to take 15-minute breaks in between each session. There's no way I can go back to back like that. That's crazy. Now, what does that mean? My day's longer. All right, well, the day's longer, but by the end of it, I know my name, and I'm not eating in front of my clients, and I'm not going to burn out, right? So you have to. It's okay if we make mistakes. I made a mistake, and it's not really a mistake. I actually talked to the client about that the next session. I said, "I got to tell you, you taught me a valuable lesson." And she said, "I taught you something?" I said, "Yes, you taught me something very valuable." And I shared with her my experience. And that was really good for us. And you know what she said? She goes, "I don't think I've ever seen a more human therapist." You know what? That's a high compliment. High compliment. We are human. We have to recognize that, right? At any time, I'm on the other side of that chair, at the other side of the room. So you have to be comfortable talking about your past. You have to be willing to see a therapist. I think therapy, quite frankly, and I know I'm in the business, but it's a scary thing to do. I started going into my own therapy about 2 years ago. It is the best self-care anybody could ever have. It is scary. It's not safe. You got to open Pandora's box, and it's not great. And I will say that you have to do the things that you ask of your clients. You've got to. So be able to hear others talk about those emotionally overwhelming situations, and be able to modulate. If you can't do that, that's the reason I entered therapy. I knew that I was burned out. And I noticed that I'd be sitting with a client, they'd be telling me their, horrific stuff, but I would feel close to tears. I felt like, oh my God, I can't take on one more of these stories. I was just burned out, really, compassion fatigue. And know that about yourself. If you're having any of those behaviors, go into therapy. Figure it out. Figure out what's going on with you. Be able to respond to disclosures with compassion, and don't feel that you have to fix it all. You don't always have to fix it. When I was at PACE, I used to think, am I the psychologist for the staff or for the participants? Because a lot of times staff would come in and they just kind of vent, vomit. And I would be sitting there and the wheels are spinning, right? And I'm thinking, what do I need to do? What do I need to do? What do I need to fix? Well, I realized after a time, this is like draining me. So I finally learned to do this one thing. When somebody, like a friend or a peer, a colleague, starts venting to me, here's what I say. Do you just need to vent and you need somebody to listen, or are you needing me to fix something? Why not ask that question? Because we are such fixers. Every one of us in this room are in this room because we fix. We are the solution people, right? So you can't burn yourself out on that. You've got to know, like, okay, can I be a listener or do I have to be a fixer? Respectful communication. Don't use clinical language with people that reinforces their beliefs about people. I let people call me a shrink. There's a part of me that wants to say, yeah, don't call me a shrink. But that's the language they use, and if they feel closer to me by saying my shrink or my head shrink says this or that, that's fine. Don't use clinical words that create an us and them. Have compassion for yourself when you make mistakes. Listen with compassion. Fuel that connection, like Brene Brown said in the video. Fuel the connection through empathy, rather through isolation and fear. Avoid language that induces fear or shame. Use non-judgmental, non-shaming language, such as she's having a hard time getting her needs met versus she's manipulative and attention-seeking. Those are different ways of framing it. And, when I do person-centered training, I talk about how when we talk to each other, or the way that we document our notes creates an us and them. Right? And just in our documentation, don't think that doesn't filter down to our care, because it does. Use first language, person who cuts themselves versus she's a cutter. Or borderline. Now, when I say borderline, most of us know what that is. But unless you are a clinician who can diagnose borderline personality disorder, do not call somebody borderline. That is a clinical diagnosis that has long life implications for that person. If you need to describe something, describe the behavior. Don't diagnose them. And motivational interviewing techniques. If you don't know what that is, you can find it very readily. There's tons of books on it. It's really a great tool. Anybody can use it. Set appropriate boundaries. Setting boundaries can be really difficult for a lot of us. But actually, when we set appropriate boundaries, especially at the beginning of our work with people, they know what to expect, and we know what to expect. And you have to be creative in that limit setting so as that you don't isolate the person by your limits. So people respond in different ways. If you are so rigid in your boundaries, people then can't connect with you. If you have no boundaries, then people are moving into your basement. So you got to know your own boundaries. Also, mean it. When you say yes, yes means yes, no means no. Don't waffle. People need to know the rules for their success. They've always had to evaluate and analyze their environment about what's safe. They're keen on that. So you've got to say, when I say, yes, we can do this, no, we can't do that, and I'm not going to make exceptions here, or if we do, we come to that decision together. But they got to know the rules. Know when you have that uh-oh kind of warning sign, that means something. Like for me, when I have the client who on a Monday morning has left 50 messages over the weekend, that's an uh-oh. Or the client, first meeting them, the first session, they say, you're the best therapist I've ever seen. The last 10 sucked. I'm like, oh God. Oh Jesus, here we go. So you all know that. You've got some sense. Understand, recognize it, and stop it immediately. That's when you need to know, okay, I need to be on alert. We need to talk about limits, boundaries, expectations. Don't talk disparagingly about other people. Go to that person themselves. Inform the clients about your limits of confidentiality. I'm surprised how many people don't do that. I mean, it's part, as a therapist, it's part of our Hippocratic Oath. It's part of what we do in ethics. We have to do that. But I'm surprised at how many people don't. In fact, they give the informed consent form and they just say, go ahead and you sign it. I'll give you a copy. No. You need to take time about that. You've got to. It's really important because when you talk about that confidentiality, that builds rapport and trust and keeps you accountable in your work. Understand why clients may not initially want to share information. They may not share it after a year of therapy, right? They may not share it initially. They may never share it. When you vent feelings about a client with other staff, do so respectfully. Focus on your reaction rather than the client's behavior. I'm feeling frustrated right now. I'm feeling stuck. I'm feeling angry at this person. Focus on your reaction with your colleagues because that's where you can do some work instead of that person just cannot get their stuff together. And when I hear that kind of language, and I've used that language, I'm not saying I'm above anybody else, but when I hear that, that to me is a sign of burnout. Because we're all in it for the right reason. We are all good at what we do. We all have great hearts. But we can get caught up in that when we're burned out and when we're at our limit. Have a self-care plan. Take time away from work. Understand that people who live with history of complex trauma may have been accustomed to a high level of drama and chaos. That's their comfort level, right? It takes time and patience for people to learn a new pattern of behavior. You can help others create self-care. Help them come up with a plan. During a crisis, when the chips are down, we all go to our old behaviors. You may have quit smoking for years, and then you go through a divorce, and you're like, yep, I'm done. I'm smoking. I mean, when we're in an incredible amount of stress, we don't do the best things for ourselves. We go back to old behavior. Patterns are hard to interrupt and keep. We relapse. Survival brain becomes preoccupied with danger. People need to be redirected and reminded of the good things in life, reminded of pleasure, of fun. I was working with a guy who was so fixated on his own death. He had COPD. And, for people who have COPD, people who have COPD, their biggest fear is suffocating because that's what happens. And it's a huge fear, a lot of anxiety. And we were always focused on his death. He didn't want to die alone. He was afraid that he wouldn't get to heaven. He'd done some horrible things in his life. And so one day he came to session, and I had bought feather boas and masks, and we had a session in masks and feather boas. Why? Because he had to laugh. And we could not talk about death while we were wearing that stuff. So we sat and laughed and had a great time in that session. And he died a couple months after that session, and I always remember it because that was the one time I had with him where he was completely a child and playful. He needed that break. Have a regular practice of appreciation for yourself. Don't force false hope on people. You'd never say, this is going to get better. It may not get better for them. But use opportunities to point out their strengths. Gee, even when it's so bad, you still push ahead over and over again. You're here. You keep going. And what is going well in that person's capacity to remain hopeful? Life can appear hopeless, disconnected, without purpose. Know what your deep connection is to your work. Most of the time, believe that you have purpose and hope in the future. And be able to talk to other people about what makes them unique and help them connect to activities that give them value and purpose and meaning. So I've given you some future reading here. Bessel van der Kolk at the very end here, that's The Body Keeps the Score. Great book. The first half of the book is really dense. It's awful, but the second half is great. I mean, it's not awful, it's just, it's dense, it's very neuroscience-y, but if you want to get to the practical stuff, the last part is great. Some other stuff for you here. I just want to thank you so much for this day. I hope it was good for you. Thanks for having me.
Thank you so much, Dr. Gibson. What a wonderful presentation. I especially was appreciative of the section on the impact of trauma. The visual of the statistics next to that hierarchy was really powerful. I really got chills whenever I saw those statistics on the suicide rate once someone rates 7+ on that ACEs assessment. And again, thank you so much on being cognizant of the audience, especially with the skill development section. I hope everyone is able to take some of the valuable knowledge that Dr. Gibson has provided us today and make a difference for the people that you serve and the people around you. So thank you so much for attending, and please visit our website if you're looking for any other information. We have some wonderful trainings on there published, and Dr. Gibson's materials will also be on there. And also, do not forget to drop off your survey up front and get your certificate. Thank you so much again. Have a wonderful day.
Thank you.